So it's my pleasure to introduce Dr. Larry Garber. Dr. Garber is a practicing internist and the medical director for genetics at Reliant Medical Group. He's acting chair of the Massachusetts eHealth Collaboratives Executive Committee, a member of the Massachusetts State Health Information Technology Council, and a member of ONC Policy Committee's Health Information Exchange Workshop. He has been a principal investigator for ARC and HHS ONC grants to develop innovative health information exchanges. Dr. Garber also co-chairs the ONC S&I Framework Longitudinal Coordination of Care Work Group. He's a recipient of the 2010 eHealth Initiative eHealth Advocate Award, the 2011 Health Data Management EHR Game Changer Award, an ONC Health IT Vanguard Fellow, and he's led the HIMSS 2011 Davies Award-winning implementation of Reliance EHR system. Please join me in welcoming Dr. Garber.
Thank you. And you may notice that I changed the title of this to say that we're giving away free care coordination tools because I know I was competing against the other room. I wanted to throw some excitement here. But actually, you're going to find out that I'm not lying, so we'll get to that. So what I'm going to talk about today is some of the stuff that you guys are all aware of and living and breathing, but I'll remind you that a lot of what we do here is to improve care coordinations because we have a lot of problems with our care transitions today. I'm also going to talk about how we've been working in Massachusetts and around the country to solve this problem, and I think what you're going to find is a lot of what we've been working on is actually going to be applicable to things that you guys are working on as well, including that free software that I talked about. So, first of all, just to remind everybody, what we're dealing with. We're dealing with a healthcare system that is in trouble, that is doing a very poor job of coordinating care for our patients, and there are consequences to that. So, for instance, when patients show up in the emergency room, a third of the time, the doctors in the emergency room are missing critical or important information on those patients. And the consequences are that people are getting admitted to the hospital unnecessarily. It's estimated that 15% of admissions are unnecessary if only they had the right information in the emergency room. In fact, there are 150,000 adverse drug events that occur from the emergency room and the admission each year because the complete medication list is not known by the emergency room physician. And that, besides the injuries to patients, that wastes $8 billion a year around the country. And it's just as bad on the other end. As patients are discharged from the hospital, there's this care plan that's been created in the hospital with expectations of what's going to happen. Patient's going to stay on this medication, they're going to be stopping this medication, this is the follow-up that's going to take place, this is the wound care that's going to take place, and that is fumbled. That handoff is fumbled 1.5 million times a year around the country. Now those are the ones that could have been prevented. There are some that couldn't be prevented, but 1.5 million times there are adverse events that are the result of that fumbled handoff. And as we know, 20% of Medicare patients get readmitted to the hospital within 30 days. There's the preventable version, those admissions that could have been prevented come to about $26 billion every year that are wasted in this country. So the government said, gee, this is a problem. They figured this out a few years ago, and they brought experts to Washington. ONC brought them together and said, okay, how do we solve this problem? How do we solve this crisis? And overwhelmingly, the consensus of that group was that we have to improve the information flow and exchange. That's the best thing that we can do, the number one thing that we should be working on in order to improve the care and care coordination and reduce the adverse events and the wasted money. So, where do patients go after the hospital? So someone did a study, and here's a hospital, and each of these boxes are different places that they can go. This is the inpatient rehab facility, this is a home, this is the inpatient rehab facility, that's a skilled nursing facility, and they follow patients. They'll go to an inpatient rehab facility, then to a SNF, then they'll go home, and then they'll go back to the hospital and back to the SNF, and to rehab after that. And patients go everywhere, and that's something that is very difficult for us to keep coordinated. Because, the healthcare system is very vast. You've got patients who are living at home, or they might be in assisted living or nursing home as they get older or sicker. They may transition to urgent cares or be seen in the emergency room, find themselves in SNFs or in the hospital, eventually maybe ending up on hospice. So it's a very vast healthcare system. And the problem is that so are the silos at vast. It's very difficult to coordinate that care. So in order to really improve our care coordination, we have to make sure that the right information is delivered to the right person at the right time, in the right location, in the right format. And so how do we do that? What's necessary in order to make that happen? Well, there are really two things that are critical and in the critical path to being successful. Number one is that you have to have the right information. In other words, you have to make sure that you're giving the information that's needed during that transition at that moment in time. It has to be in the right standard so it can be used. And then the other thing is that you need the right tools to be able to make that communication possible. So the government got that, and they gave some grants out. They realized that for meaningful use, they left out all the nursing homes and home health agencies and community-based organizations and half the healthcare system. So they said, well, let's we know we gave $26 billion to the hospitals and doctors, but let's throw out maybe $8 million to nursing homes and home health agencies, and that's what they did. And so Massachusetts received one of these grants. It was called IMPACT, Improving Massachusetts Post-Acute Care Transfers, but actually it should have been IMPACT, Improving the Nation's Post-Acute Care Transfers, because we really had an eye much broader than just Massachusetts. And the purpose of this grant was to exactly do what we had talked about, which is improving these transitions. So part of the study was to make sure that the right standards are in place. The second half was to make sure that we have the right software and tools in place. And what we're doing is piloting this in central Massachusetts, just due south of here, and then measuring the outcomes from the work that we're doing. So let me first talk about the standards, because this is important. The standards are changing, and what you've been used to, what you've been working towards. How many people know what a CCD is? Okay, it's going to go away. Ooh. So let me tell you all about this. So stay tuned. So first of all, the CCD came from Massachusetts, and most people don't know this. Turns out that in Massachusetts for decades, we've had this paper form in the hospital. The Department of Public Health talked to some hospitals and said, well, what kind of information can you send when you're discharged? And they said, well, this is what we've got. And they said, okay, fine, let's do that. And so at the time of discharge, the doctors got to page 1, the nurses had page 2. I'm not sure who fills out page 3, I just know it's not me. And so these are all filled out, and then they're sent with the patient to wherever they're going. So folks at Mass Medical Society and some other people got together and said, wouldn't it be great if that was electronic? And so what they did is they took that 3-page form and turned it into a CCR, the Continuity of Care Record. And then the folks at HL7 said, wait a second, we're the standards organization that really counts in healthcare. So they converted that into the CDA document architecture and created the CCD. So the CCD came from Massachusetts from that 3-page form that was started by the hospitals doing kind of what they felt that the people needed when they left. So Dr. O'Malley, Terry O'Malley, he's head of geriatrics over at Partners down in Boston, Mass General, Brigham. He had this brilliant idea. He woke up one morning and he said, maybe we ought to ask the receivers what it is that they need when they receive a patient. And so sure enough, because maybe the receivers actually have a different notion of what's actually important during transitions. And so that's what we did. Part of the study was to ask the receivers what exactly do they need. Now, in healthcare, there are lots of different transitions. I mean, there are at least 196 different possible transitions because they could be sent from the hospital, from the emergency room, from my office, from behavioral health, from long-term post-acute care, from the nursing homes, from home health agencies. Lots of places that they could come from, and they pretty much can go to almost all the same places as well. So there are tons of different transitions that are possible. We've also got the patient and family here, let me point that out so Lisa doesn't yell at me.
She already did.
It's here, it's there.
I pointed it out,
Okay.
it's not going to hit you.
Okay, thank you, I appreciate it. So there are lots of people who are receivers of the information. And, we thought about that and said, oh my God, this is a lot of different transitions, and we know that some transitions are going to need different information than other transitions. So, instead of having, almost 200 different types of documents, we said, well, first of all, we need to sort of prioritize this and try to get a handle on it. So we analyzed different kinds of transitions and prioritized them as to which are the most common ones, which are the ones that have the sickest patients, which are the ones that the information has to be most timely, that we need it now. They're going to the emergency room, you don't have the luxury of sending it tomorrow, they need the information right now. So we evaluated all that, and the ones that are circled here are the ones that we felt were the highest priority, and those are the ones that we were tackling. So there are about 49. And then we did a survey. We found lots of different people in Massachusetts who were willing to take this survey, looking through a list of candidate data elements, saying, which of these do you really need when you receive a patient from all these different places? Which ones are sort of nice to have, and which ones do you not need at all? And they went through, and it was interesting. One of the data elements was patient's name, and we got some surveys back that said that the patient's name was not needed. Like, oh great, we messed up on our data analyses and everything. Well, it turns out those were the patients who filled out the survey. They said, well, we know my name, I don't need my So anyway, so we sent it to patients, we sent them to nurses and doctors and therapists and social workers and care coordinators and secretaries and anybody that we could find, 12 different types of user roles. We also sent them to lots of different types of organizations, nursing homes, skilled nursing facilities, long-term acute care hospitals, physician practices, community-based organizations, emergency room departments, inpatient wards, everybody. So we really got a nice view of the whole healthcare system. And what we found from this survey, we got over 1,000 surveys back that we analyzed, looking at all these data needs of receivers. And we figured out which data elements were necessary and not necessary for each transition. And we found that, that all of the data elements plus more that we had set out there were needed at least for some transition. And but certainly they weren't all needed for every transition. So if we just did them for the most important ones, well, that was 49 transitions. That would mean we'd have to have 49 data sets. And we've got the CCD, so we'd need, CCD version number 1, 2, 3, 4, 5. So, and we realized that was nice, but 49 was far too many. So we had to rethink this and figure out how we could make this more manageable. And so we realized there are actually 5 data sets that we can lump everything into. And all those transitions that you saw, all those almost 200 transitions, really fall into basically 5 different categories. And so maybe 6, but it's, most of them are covered by 5. So the first 2 are when you're sending someone for a test. They're just going to go, something's going to be done to them, and there's a certain amount of information you have to send with the patient, sort of enough to make sure that the person who's doing the procedure, if they run into some trouble, they know what allergies the patient has, they know what meds they're on, they know if they're on oxygen, how much oxygen, sort of just enough to make sure they can safely do the test or procedure on the patient. And then the other net pair is what's the information that's then sent back. This is what I did, I gave them this medication, this anesthesia, this is what I found during the test. And so it's just some basic information, so that's the first 2 data sets. The third and the fourth data sets are the ones where you're sending someone for an evaluation, a consultation. You're sending them a little bit more information this time because you're saying not only here's what the patient's meds and allergies are, but I've also done these tests already, here are the results, what should I do next, what's going on? And then and paired to that is the consultation note that comes back saying, okay, this is the evaluation that I did, these are the tests and procedures that I did, this is what I think is going on, this is what I think you should do for a treatment plan. So those are the next 2. And the emergency room is that as well. In other words, when you're sending someone to the emergency room, the idea is that they're hopefully going to be going back home. I mean, most of the time they do. So it's really like a consultation just for a sicker patient. And so they would also, use those same data sets when you're sending someone to the emergency room, when you're getting someone back from the emergency room. And then the last one, that's the biggest data set. That's the transfer summary. That's when you're sending someone from one care setting and one care team to an entirely new care setting and care team. They've been in the hospital, they're going now to a nursing home, it's a whole new team that's going to be taking care of them. They need to know everything about the patient because they're starting from scratch. So another way to visualize this is that the data sets sort of build upon each other. You know, they reuse the data elements from the smaller data sets and fill up into the larger data set, so that the biggest one basically contains all of the data elements of the smaller one. So then when we went back and we analyzed it, we said, well, do those 5 data sets cover all the different transitions? And they do. So we've got all the information covered with just those, all the transitions covered with just those 5 data sets. So then we took it around Massachusetts, and we said, okay, we had these people who did the surveys. Let's take it to more groups in Massachusetts. So we found a bunch more willing groups that went through the surveys, gave us back some more information. And then we went around the country, and we went through multiple national organizations, asking them to review these. We got a lot of great input from around the country, from different private and public organizations, even some states, Ohio, Rhode Island, New York, New Jersey. They were all working on their own, similar kinds of forms, a sort of a universal transfer form. And so they had collected data elements, and we reviewed those to make sure that we had everything covered. We looked at MOLST forms and POST forms and other advanced directives and e-POSTs and things that were done around the country, again, to make sure that we were covering it all. And then we went international. So we've taken this to HL7, an international organization, to IHE. We've gotten input from them as well on work that they've been doing and making sure that we're getting it all. And as part of this work, we realized, the care plan has sort of really been left out of the discussions. As we're talking about transitions, the fact is that a lot of the care is still shared, and that the care plan, whether it's shared care or whether it's transition, is important to all of those. So we realized that the care plan is a subset of all of these, and as is the home health plan of care, which is a flavor of a care plan, that also known as the CMS 45, or people who are old like me know it as the HCFA 45. That's where, when the home health agencies are sending the plan of care back to the primary care physician to make sure that they agree with it. So the care plan, we realized as we talked about it, has lots of different components. Health concerns, the goals for those concerns, the interventions that you're going to put in place to hopefully achieve those goals, your assessment of those interventions, and to identify the patient's status, and the care team that takes care of all of them. So there are a lot of different components that make that up. And so we added a lot of data elements because of that care plan. And so we went back and we said, okay, now we've got all of these data elements that are necessary. Well, how does this compare to the CCD? The CCD that all of us are working hard to make sure that that's what we can pass around. So the CCD has about 175 data elements in it. That's approximately, depends on how you do the counting, but it's about 175. So it turns out that just a basic data set to send information around needs almost double that. It needs another 150 data elements. So far more than right now what we're all striving to send is only half of what you're supposed to really be sending around for transitions. But wait, if you also want to take care of care planning with all the goals and barriers and all the different aspects of a care plan, you need a lot more. Almost 500 data elements are needed to comprehensively handle a full transfer from one organization to another. Almost 3 times as much as what we're all working to achieve right now. So that's why, as I said, the CCD is with us today. That's the best we have, but that's going to be evolving over the next several years. So I'm glad you came today, because you're the first ones to know that. So, now, we also realize, some of them can be fit into the CDA, the consolidated CDA. You can figure out how to put some of those data elements in. But it turns out a whole 20% of these data elements, almost 100 data elements, there's no way to describe them in the consolidated CDA today. So that's something needs to be done about that. So first, before we changed the world, we said, okay, we've got all these data elements, and can anybody use them? I'm a physician and I'm busy, and so are my staff, and we don't have time to fill out data elements. And so, this may be just an interesting mental exercise, but it may not be practical. So what we did is, part of the study, we tested this. We started on paper because that's all that we had, and when we tested this last year. And what we did is we got 16 organizations together in central Massachusetts. We picked them because they were already partners, doing a lot of care transitions already among them. We had two large integrated healthcare systems with hospitals, 2 large group practices, mine and one was a federally qualified health center, 2 home health agencies, a long-term acute care hospital, an inpatient rehab facility, and 8 SNFs. And all of them agreed to work together on testing this out. And so we got them all together. We had these learning collaboratives. That's a whole other lecture on what we did. But we basically agreed to how we were going to convey information with patients, for now on paper, eventually electronic. And we did this for several hundred transitions. So what we had each organization do is, when you're about to send the patient to somebody else, whether it's the emergency room or discharging them or to a consultant, you're going to put together a packet of information on paper. If you've got the med list, photocopy it, stick it in the packet. If you've got the problem somewhere, photocopy it. If there's stuff you're not collecting, put it on another piece of paper, create a tool to collect that stuff. And then stick it in the envelope and send it, filling out a survey on the envelope as to whether you were able to get all the information that the patient needed. Figuring out as the receiver, did you get all the information that you needed when you received this packet? And the results showed that the vast majority of the time, the senders could get all the information that was needed by the receivers. Interestingly enough, the vast majority of the time they were already collecting it. It was just they never realized that it was something that the receivers needed. So they always put together whatever their standard packet was. And they found it was an enlightening experience to go through comparing what they normally send and what it is actually that the receivers needed. Then on the flip side, we checked and said, okay, as receivers, did you get what you need? And the vast majority of the time, the receivers got exactly what they were looking for. So it actually worked. It actually did what it was supposed to do. Now, what I found the most interesting is, you see this 8% that didn't get what they needed? That was home health. Home health needed more data than any other part of the healthcare system. So I was shocked. What? These aren't the sickest patients. What do you mean they need more information? But actually, if you think about it, it actually makes sense. So when you send someone to the emergency room, when should they be seen? That day, right then. When you send someone to a nursing home, to SNF, when should they be seen? That day. When you send someone to home health, it could be you need it then to be seen today, or maybe the first visit day is tomorrow, or maybe it's the day after that. So you need to specify in a data element what the expected day is that they're going to be showing up to see this patient. How about when you send someone home with oxygen? If you're sending them to a skilled nursing facility and they need oxygen, they've got one vendor. They've got the vendor for the oxygen that they always go to. They know where to get it. When you send someone home, it could be one of dozens of different oxygen vendors, because it depends on the insurance, it depends on the physical location that you're sending the patient to, and so you need to specify. When the visiting nurse goes into the house and there's no oxygen, they need to know who to call. So they needed the data elements. Who's the vendor? What's the contact information? Again, more data elements than what anyone else needed. So we're going to be actually going live next month doing this electronically. So we've got some tools in place that are going to allow us to test this electronically. That's what the next part of the lecture is to talk about those tools. But we expect to be able to, when we get things ramped up among the 16 organizations, we'll be sending over 10,000 documents a month testing this data set. So this is great, but we don't really just want to do this in Massachusetts for fun. We really think that we've learned something valuable. In fact, the federal government wants us to be spreading this around. And so we wanted to make sure that others could benefit from the work that we've been doing in central Massachusetts. So the way standards are made these days is that the Office of the National Coordinator, ONC, has all these people that work for them. And as part of that, they set up, they have a policy committee. And the policy committee figures out what's important. I mean, they make priorities. They say, okay, it's really important for meaningful use to go ahead and be prescribed and to send information during transitions and to have clinical decision support and all that. So they say these are the things that are important, and then they hope somebody else makes the standards to make sure that it happens. So what they did is they set up something called the S&I framework, which is it's an online network of collaborators. It's sort of an online collaboration tool where people from the private sector, the public sector, healthcare, from vendors and industry all get together online and work together to try to create standards in sort of a rapid process so that they can be used. And then what happens is been happening is that they then take those standards to HL7. HL7 then goes through a process to ballot them. And then the standards committee, which also is part of ONC, looks at them and says, okay, this is a good standard, we like it, it makes sense, it's being used, and that's the one that all the EHR vendors are going to need to use from now on, like the consolidated CDA with the CCD. So, and then Secretary Sebelius signs it, and it becomes part of meaningful use and EHR certification. So what we've done is Impact Project is now part of this whole process. And so we've been working with the S&I framework to review our standards, to improve them, to optimize them, then taking them to HL7 ballot, which we finished last month. And now we're going through the reconciliation process, which is going to take several more months. And to make sure that we actually create standards that EHR vendors can actually work with. This is just a picture of all the teams on our work group, but we worked on the care plan, we worked on the care transition documents, we made sure that we were coordinating with other organizations. In fact, we've done a lot of coordination. This is just for your reference if you needed to talk to anybody. These are the leads of the teams that are working on the S&I framework. But we've been coordinating with a lot of different groups. Besides the S&I framework, we've been working with CMS, with ASPE, which is under Health and Human Services, the Department of Defense and the VA are interested in the work that we've been doing. We've been coordinating with them, IHE, AHIMA, and HIMSS with the continuity of care model. So we've been working with a lot of other organizations that are working on this exact same thing. And what we were able to do, and I have to actually point out that New York State, I am forever indebted to them, and so should the nation, because they actually ponied up some good dollars to help with the standards development process. And so they, along with CMS, put in some money, ASPE, have all put in money to help creating this ballot process in HL7. And what we did is the three largest documents are becoming part of the consolidated CDA, as well as the care plan with the home health plan of care are all becoming part of the consolidated CDA. That's what we balloted last month. That's what's going through reconciliation now. That's what's probably going to be published in January officially as a standard to be used. At the same time, the policy committee is already saying, for meaningful use stage 3, right, we're going to starting stage 2 now. For stage 3, they want the EHR vendors to be able to support this. That these data sets being that they've been added to the consolidated CDA, they want these to be part of the EHR functionality for meaningful use stage 3. Now obviously that's not carved in stone. We don't know when meaningful use stage 3 is coming. We don't know what it's going to look like in the end, but that's the trajectory, is that the CCD will now be, there will be the expectation that you can handle this as well. So, I already talked about that. So the software tools. So how do we, this is great. Patients in the hospital, they have all this data, we put it together in their EHR, it's electronic, and a nice little CDA document, we send it out in a direct message. And then there's this nursing home sitting on the other end about to receive the patient. They don't have an electronic health record. At least in our area, only one of the 8 homes had an electronic health record. So how in the world are they going to receive this electronic document and do anything good with it? For that matter, when they're the ones that are the sender, there's this nursing home and they're about to send a patient back to the emergency room, or they're sending him home to home health, how can they generate a CCD, a CDA document of any kind, if they don't have the electronic tools to do that? And so that's where we came up with the idea of land and sea. Because we're Massachusetts, so what if by land and to it by sea? We had that's what we did, and then we had to figure out what they stood for. So what they stand for is land is the local adapter for network distribution, and what that is that's a little computer. It's about the size of this microphone, and except it's rectangular, and it's got an interface engine inside of it. It's actually the Rhapsody interface engine made by Orion. But what it does is that it can allow someone who does have some electronic data, like an electronic health record, it allows them to connect to health information exchanges. It's not that easy to just plug and play these EHRs into networks. And so this helps as an adapter to help make the connection better. We anticipate that land won't be needed a few years from now. When all the EHRs have gotten to the point where they can talk to provider directories and certificate authorities and send direct messages or whatever form of standard communication using IHE XDR protocols, when they can all do that plug and play, then LAN will go away. But for now, LAN gets us up and running faster. But that still doesn't help the nursing homes. They don't have anything. And so that's what C is. C is sort of a surrogate EHR environment. It's like an EHR light, or actually an EHR really, really light. And it's just enough for the folks in nursing facilities and home health agencies, if they don't have EHRs, or community-based organizations, or dentists, or behavioral health, or whoever else doesn't have an EHR to be able to participate. And the way it works, it's kind of like Gmail, or Hotmail, or Yahoo Mail. You take your web browser, you log into your mailbox, and you see what mail's there. You open up the mail, maybe there's an attachment, you click on the attachment, you can see the attachment. That's exactly what this does. So it's right now designed to attach to Orion's mailbox application. And what happens is when you click on the attachment that's a CDA document that they just sent you from the hospital, it opens up C. C is your viewer, so you use that to be able to see this document. And then, let's say that patient 2 weeks later is going to be going home to home health. You can actually start with the document that you received from the hospital. You can update it. Well, let's see, they're now taking this med. They're no longer taking this because now they're allergic to that. Their wound looks like this. They're walking this well. So you basically can update what you received from the original CDA document and then send that on its way. So that's what C is for. It allows them to sort of participate in the receiving and also efficiently allow you to participate in the sending, reusing information wherever possible. So here's some screenshots from C. This is just showing you that if you have a document already, you can either copy the entire document into a new one, or you can copy pieces of it. So maybe you just are interested in copying the advanced directive section here, from a prior one into the one that you're generating. You can kind of pick and choose which ones you want to copy forward. You can enter data in some templates. This is the question, is the vital signs. There's a nice little button you can calculate the BMI, because no one really knows how to calculate that, so that's what the button's for. Then also, wherever you put anything, you can always put in free text. So, even with the vitals, you can add paragraphs of free text about, why their blood pressure may be high with this particular reading. One of the things that the nursing homes have figured out is that, they already have sort of an MAR with the, a medication administration record with their vendor for the, who's delivering their medications. And they found that they can cut and paste, copying the med list from there, pasting it into the window here, and this way it's efficient for them, because you got to make it efficient and usable in order for it to be successful. So also there's type forwards. You can type the first few letters. The problem list will show things that match, or the medication list will show things that match. Again, just to make it easy to use. Then we also said, there is already a lot of clinical data, even in these nursing homes that have no electronic health records. They do bill. They have this MDS that everyone's filling out. So do the nursing homes. They got the home health agencies. They've got Oasis, and in those there's clinical data. There's assessments of the mental status, the functional status, the wound status. All that clinical information is being recorded periodically. And gee, wouldn't it be nice if you actually could just take some of that clinical information and reuse it as well? Why retype what their wound looks like or what their functional assessments have been? Just sort of scoop that and suck it right into your CDA document that you're creating. And so the folks in Pennsylvania came up with this one. And we're using it in Massachusetts, or we're about to use it in Massachusetts. And so what happens is, you've got the MDS or Oasis forms, and what they've got is a little piece of software that runs on the computer in the facility or in the home health agency, and it gobbles up that form and creates a CDA document that is then mailed using direct. And basically what we have to do is mail it back to your own mailbox. So the nursing homes basically send that back to themselves. So now when they're trying to do their work, they've got the discharge summary from the hospital, they've got their latest MDS assessment, they can pick and choose what they want to put into their new document, and then they send it on the way to the patient. So just here's a visual way of looking at it for those of you who are picture people. So here's the healthcare system. Here's your hospital. here's the nursing home, here's the, or used as a SNF in this case, here's the primary care, that's me, primary care physician before actually I think that's going to be only look like in a few more years, bald, and the home health agency. So the hospital goes and creates, I'm going to call it a CCD plus, just because I don't really have a good name for the transfer sum rating. So the CCD plus, and then they're going to send that through the health information exchange. And it's going to go into the mailbox, the C mailbox for that nursing home, one mailbox per the facility. So what happens is that in that nursing home, they've identified there are a few nurses, that, there's the director of nursing, there's an intake nurse, there are a few people that want to get notified that, that there's this new information. So they get text messages saying, you've got mail. So they go ahead and look into their browser, they go up and look into their C mailbox, and they can see when the information was sent to them. They can print it out, use it for the paper record, they can do whatever they want with it. Care continues, they go ahead and do their billing, they've got the MDS form that's created, that gets sent through the Key High transform product, and it's mailed into their mailbox. So that then when it's time to send that patient to wherever they're going next, whether it's the emergency room, whether it's home, they can go ahead and use this information to create the new document, and then they can send it electronically through the state's health information exchange using direct to the primary care physician and to the home health agency. So they can be good partners in this electronic network. So we're making this available, some of it available for free. So land is owned by Orion, so you have to pay them for that. But what we do have is that we're making available the mappings. So there is some mappings that was made part of this, and that will be available for free as well. So you don't need to buy it in order to at least get the information and do it yourself if you choose, or you can partner with Orion to use this. C, on the other hand, was written by Lantana, and did a great job. It's written in, this is actually wrong, it's written in JavaScript. I'm sorry about that. And we're making it available for free through open source software, so you can take it and you can do whatever you want with it, including enhancing it if you want. You can, right now this is sort of plug and play with Orion, but in other states that don't have Orion, which I know there's at least one up here, you can modify it, and it's probably not that expensive on the big scheme of things to modify it to work with other health information exchanges. Because this is really doing, the C product does most of the hard work, and then it's really a pretty simple connection to the HISP mailbox that the health information exchanges have. So, in summary, first of all, as we started out, we all know that communication failures are extremely expensive, wasting billions of dollars every year, and harmful, injuring millions of patients every year. And that the standards that we've all grown to love, the CCD with the consolidated CDA, are evolving to meet the real needs of the healthcare system. We do anticipate this is likely to be part of Meaningful Use Stage 3 and part of what EHR vendors are expected to use. We'd love to have you pilot these standards. The latest SNI framework group that's being started up is focusing on pilots. It's sort of like a support group where we get together and say, well, how did you solve this problem and how are you going to handle this? And so if you go to the SNI framework, Longitudinal Coordination of Care website, you'll be able to see that there's that pilot site where you can contact me and we can get you, joined into that if you want to be piloting this now that it's becoming available. Thank you. And then, floated too early. And then the last thing is that there is software that we've created to help people fit in to use these new standards, to help accelerate the use of these sooner as opposed to later. And if you're interested in taking advantage of Land and Sea, just let me know. So with that, I think we ended early enough, or maybe we're getting back on schedule, and I can take some questions. Yes?
Would you spend some time talking about plans of care and all those interprofessionals who are involved with plans of care, and what I think is a new term for me, longitudinal care plan? How is all that going to work? Are people going to be tripping over each other? Is there a truly multidisciplinary document we're going to work with? How's it going to work?
So To answer your question, yes, people are going to be tripping over each other. So, what we do, we know that you're right on the money, that the end game is that we have to figure out how exactly to coordinate this sort of master care plan or longitudinal care plan or whatever, or just plain old care plan with all of the different...
You name it so that people know exactly what it is, because people go nuts over terminology.
Right. We're actually, the term that we're trying to use is care plan. And that a subset of the care plan are plans of care, treatment plans, things like that. So we're trying to keep it simple, but that's not going to happen. But the idea is there's this notion that in the universe there's this one monster master care plan that belongs to a patient, and that there are lots of different people working on different aspects of it. And that is a whole other presentation also. And the idea is that somehow there need to be ways to coordinate that, and people are trying different ways. There is an HL7 group that's working on services to try to manage that coordination. But we figured, while we're trying to get to nirvana, and all the details of how you can actually reconcile plans of care into a care plan, we figured that we at least needed to define what are the data elements that make up all of these. And so that's the stage that we're at right now, is making sure that we've got all the buckets, or as Dr. O'Malley calls them, all the Legos, that can be put together so that, at least we're putting them together in standard ways with standard components that may be somewhat interoperable and interchangeable. And then the next step is to figure out how to actually coordinate these things so that so there isn't chaos. So we're all speaking English now, but we still haven't figured out how to necessarily talk right to each other. Other questions? Yes?
This is kind of a question on how C functions. If you are a user of C because you don't have an electronic record, are you only ever seeing the most recent CCD plus, or when you log in, if this is the third time you have this patient, you see the last 3?
So that's a great question. So the question was whether, because we're being filmed here, and I need to know what you asked. So the question was, when you're looking to see, what do you see in C? Especially if there have been multiple documents that have been sent in. So C does have some document management built into it, so that as you look up a patient in C, you can see their last, however many there are, and you can pick the most recent one. It also stores, it's also storing information back to the mailbox, the HISP mailbox. So there are actually almost 2 different storages. There's the one that first received the mail, and then it passes you to C, and then C is keeping track of versions of documents within it. And so it's possible that you can find older ones that you've received, multiple MDSs that you've sent to yourself. Those all find themselves in C. So it's really, you can delete them out of your regular mailbox, but they stay in C itself.
And is it being saved by patients? So say you have a patient that came from one facility, same patient came from another facility, would you have multiple of that patient from both facilities, or is it?
That's right. There's no reconciliation, so you just stack these up. These are the ones this is the one you received from when they were admitted from home. This is the one that you received when they came back from the skilled nursing facility or wherever. In other words, they all just come in together, and it's up to you, most likely, to find the latest one and work with that, and then move it forward. It's not a full EHR. There's no reconciliation built into it. But one of the ideas we had is that because it's open source, that a creative vendor could add that functionality and sell it. Go for it. So, you could add functionality to this to make it more useful. Other questions? Excellent. Oh, wait, one more.
Well, let me just ask you, said you were looking for organizations to be pilots. Are you specific as to the type of organization?
Nope, anybody. We're in central Massachusetts.
Obviously.
Right. And, and so, as long as you've got partners in the trade, then it makes sense. Yes?
Is C available for distribution now?
C's not available yet. We anticipate it's probably going to be December or January that it's actually available. We just want to make sure that, as I say, we're about to go live next month. We want to make sure that we got all the bugs out and that everything works well before we sort of let it out there for people to start using. Great. Well, thank you very much.